As a surgeon dedicated to the treatments of prostate cancer, I face with my patients this very specific question. Yes, my patient is diagnosed with prostate cancer, and him and I are trying to find out what is the best approach. And so the question is, well, doctor, how bad is it? What is my risk? And certainly that's a very relevant question, because navigating through the different therapeutic strategies sometimes I could recognize is quite confusing. And so what we use as surgeons, as healthcare professionals dedicated to the treatment and the management of prostate cancer, is we use these clinical elements to help us discern patients with high-risk disease from those with low-risk disease or intermediate. And those are the PSA level, which is a blood draw, a PSA level greater than 20 nanogram per mil puts a patient in a high-risk category. A clinical stage that is a T3A, which means that when the doctor feels the prostate, they appreciate a likelihood that the cancer may have broken outside of the capsule of the prostate or the skin of the prostate. And finally, the Gleason grade, which is gives us insight on the biology of the disease, how fast growing a cancer is. And the Gleason grade today is either a 6, a 7, an 8, 9, 10. And we can lump them either in a 6, which is a slow-growing cancers, a 7, which is intermediate, and 8, 9, 10, which are part of more of a fast-growing cancer. So then for a high-risk prostate cancer is one that has any of these, either a high PSA greater than 20, a clinical T3A, or a Gleason 8, 9, or 10. With those, any of these elements, or either alone or in combination, one of the definitions would apply, and these patients could be considered as having high-risk prostate cancer. Now, others use different definitions with different statistical methodologies, such as a nomogram, which incorporates all of these elements and then gives us a score, and that score correlates to a risk on a line. And then that's a very good way to assess the disease. Sometimes it's not very easy to understand or to grasp because we like the categorical decision model, but the nomogram may be actually a more reflection of the true risk, because the risk is not men with prostate cancer, and I would say that to men in prostate cancer, it's very hard to compare oneself to a friend, to a colleague, to somebody we know that has prostate cancer, unless we have these very specific elements. So now I will get back to how do we treat high-risk prostate cancer. For a number of years, we have used single modality, either surgery alone, or we have used hormonal therapy and radiation in combination, which has proven to be better than radiation alone. But yet, it leaves a group of patients, and a sizable group of patients, that their disease just does not respond to this treatment. And in recent years, we're happy to see that there has been incredible drug discovery that showed that it prolongs life. Those drugs have shown that they prolong life in men that have cancer already spread at the metastatic level. But now the medical community is looking at, could we use the power of all of what we have together to focus on a cancer that is still in the prostate, although it may be an aggressive cancer, and try to treat it and basically halt the disease from going further. And there are clinical trials, which are research protocols. Sometimes your doctor may ask you to be part of it. I think you should consider that and read the information quite carefully. And these trials are looking at what is the best strategy with all the tools that we have. We did not have them a few years back, but now we do. What is the best strategy to halt the disease and yet impact the quality of life of patients to the lesser extent possible?